Without a doubt, this election year is stirring up a number of issues at the national level, including a number focusing on healthcare. We have an exciting panel this morning comprised of national experts in healthcare policy and politics. Moderating this morning's panels are Dr. Kavita Patel and Dr. Marc Samuels. Dr. Patel is a principal at ADVI in the Life Science Vertical and is a Fellow of Clinical Transformation and Delivery at the Engelberg Center for Healthcare Reform of the Brookings Institution. She has worked with the NCCN Best Practices Committee and has participated in multiple NCCN programs as an expert panelist and speaker. I could go on, but we would take too much panel time about Kavita's stellar credentials. I think she will speak for herself when you see her panel moderation. She is a practicing internist, and she also has expertise in clinical integration models, workforce development, and health information technology. The other moderator this morning is Marc Samuels. He is President and CEO of ADVI and is responsible for the strategic vision, leadership, and operational execution of ADVI, as well as development of execution strategies designed to grow business outside of North America. Marc has been involved in many of the most seminal policy issues across public and private payers, and his list of credentials includes the White House Office of Policy Development, the Vice President's Office, the Pentagon Office for Health Affairs, the Texas Health and Human Services Commission, and the Office of the Governor of the State of Texas. So I would like the panel to come on up to the podium, and I will turn the session over to Dr. Patel and Marc Samuels.
Oh no, they should come. Are they coming?
They're not. They're not. Good morning, everyone. All right, we're going to actually, why don't we go ahead and have our panelists join us, because we're just doing this seated forum instead of having podium time. And we're all going to just kind of get seated, and then we'll do brief introductions. And I feel like if people are looking for seats, they can filter out. There's always the front row. It's the same way it was in medical school, where, well, now nobody goes to classes anymore. Everything's just virtually on their laptops. But Marc, why don't you go ahead and introduce? We're going to split. Marc and I are going to try, in the spirit of how large this conference is and how heavy this agenda is for this morning, we wanted to try and actually tackle the morning session kind of in two halves, so to speak. So I'm going to kind of help go through the first half, and then Marc's going to kind of round us out. And then what we've done to try to deal with what we think might be an onslaught of questions is we've had some issues, questions, and kind of topics in advance that we know the audience will want to get to. So we're going to have some kind of moderated discussion and then have a little bit of like hot potato questions just to get the conversation flowing. And then we'll do a time check to see how questions from the audience may or may not be able to be integrated due to time. So we want to get everyone out on time because your program is pretty rich, and we want to honor the speakers that are here. So
sure.
Why don't you go ahead and introduce two folks, and then I'll introduce the rest of the panel, and we'll get going.
Perfect. So the first panelist I'd like to introduce today is Dr. Scott Gottlieb. Scott's a resident fellow at the American Enterprise Institute. He's a former senior official at the FDA and CMS, a frequent writer and contributor to Forbes and the Wall Street Journal, and still finds time to practice medicine, and is a faculty member at the NYU School of Medicine. And the other panelist I'd like to introduce is Lan-Hee Chen, down on the other side. Lan-Hee is the David and Diane Steffi Research Fellow at the Hoover Institution, where he's focused quite a bit on health policy issues. Director of Domestic Policy Studies in the Public Policy Program at Stanford. He's a survivor of 4 presidential campaigns. Most recently, Marco Rubio's 2016 bid.
3 in this cycle.
3. That's right, yeah.
3 in 1 year. Romney in 2012.
And he looks younger, not older.
And served President George W. Bush at the Department of Health and Human Services. And currently is on the bipartisan Social Security Advisory Board appointed by President Obama.
Very bipartisan. All right, so I have the pleasure of introducing 2 people whom I humbly call friends. On your far left is Cibele Bjorklund, and I don't think that was meant to be political, but it probably is a little bit. So Cibele is currently a senior fellow and distinguished visiting scholar at the Georgetown University School of Public Policy. Where I got to know her best was in her role as Democratic Staff Director for the Health Subcommittee on Ways and Means, and she was all those titles and words don't really do Cibele justice, because Cibele was kind of the guardian or the keeper on the House side of what I would say was like the moral imperative of the Democratic Party, which on any given Sunday sometimes we wondered, but Cibele never wavered. And so she was always when I worked in the Senate, there was always these kind of, as Liz knows way too well, the Senate and House would have to kind of come to agreement on certain things, and Cibele was always the person you did not want in the room, because if you needed to have concessions, Cibele would work very hard to make sure you could justify why you needed what you needed if it was different from what the House was doing. So that's Cibele all the way on the left there. And then 2 seats over from her is Liz Fowler, who currently holds the title of Vice President of Global Health Policy at the Johnson & Johnson Corporation. And prior to that, if any of you have had a chance to read The Bitter Pill or any of the numbers of books and publications written about the Affordable Care Act, you'll see Liz's name very frequently mentioned as one of the main architects, especially on the Senate side, for the Senate Finance Committee, under the chair of that committee, Max Baucus. And Liz was also one of those people that anyone who worked in DC or worked in Congress, even still to this day, has one of those reputations for not only being bipartisan, but being very kind of heavy on the substantive side. And I would say for a group like NCCN, where most of you are steeped in a day-to-day of clinical work and research, Liz was one of those people that tried to really take and adopt the principles from that. So you can tell I'm a little biased as well, but I think, I would like to say that all 4 of these people come from a very kind of humble beginning of trying to understand the problems and how they can actually play a role in some of the solutions. Mm-hmm. So with that, I do want to ask, because I know that the title of this talk, we're going to get into a little bit of the politics, maybe a lot of politics, but we actually did want to, because of how senior of a role each of these individuals have played in several administrations, but also currently their thinking on kind of just in general, where are we in healthcare? We know that this is a group that focuses on cancer care, but let's talk very broadly, because we're now obviously in a critical election year, as well as kind of a critical time when President Obama is going to be leaving. His signature Affordable Care Act has certainly had its bumps and certainly still kind of working through its implementation. But how are we generally doing? What are we doing well? What are we not doing well? And just take us through your opinion of kind of where we are now. And I'll start, let's just go ahead to make it easy and kind of start on the far end and then work our way back. So Cibele, do you mind telling us your viewpoint?
Well, I think we've reached a bit of an inflection point. It's an exciting time, I think, when you're looking overall at the healthcare system, with the menu of changes that the ACA has put forward, which included, of course, tremendous changes to Medicare, as well as private market coverage and other initiatives to try to better align the incentives. And so for me, when I'm looking right now at the system as a whole, I think the efforts to better align the 3 Ps of patients, physicians and providers and payers, to better align the incentives to encourage the right care at the right time, is an exciting concept, long overdue, but still embryonic. I think our challenge is, as we're looking at the different payment changes to try to drive that integration, you end up with counterbalances on the other side and still a lot of unknowns. So there's a lot of promise there, but we still don't know how to do it right. And I think the challenges that we have in the US is that we do have a unique system. We're not like anywhere else. And to do it uniquely American, we have to admit that we're fairly fractured, and we remain so even after the ACA. At least we've made a better dent in coverage, but we still are going to have a lot of churn that is not necessarily present in other countries to the same degree. And trying to integrate care in a churning system, I think, is a challenge. Challenge especially for oncology patients and other high-need patients.
Great. Lonnie, your perspective?
Yeah, I mean, I'd just make 3 observations. I'd say first, I think people in the public policy environment, in the political environment, are sick of talking about healthcare. And I hesitate to say that because there is a lot of political dialogue around healthcare. But if you look over recent American history, the reality is that when you have major policy change, as we have with the Affordable Care Act, the likelihood that we're going to see further policy activity in that area, I think, is pretty minimal. So I do think that, you know, to a certain degree, politicians and policymakers like to have a rhetorical discussion about health care. But the actual substance of what will happen here over the next several years, I think, will be fairly constrained within, you know, a set of boundaries that that won't allow necessarily for really significant policy change, but will, you know, stimulate some important change in a few targeted areas. I think the second issue is cost is still a big problem. It's a big problem politically. It's something that politicians love to talk about, but it's an actual on-the-ground problem that a lot of patients continue to struggle with. And as a result, all of the issues that we'll talk about with respect to health care are going to be viewed through the lens of cost. I mean, just to take drug pricing as an issue, you know, it seems to me that the excessive focus on the pricing question is due in part to the frame that we view healthcare discussions through, and that's primarily one of cost. And then I'll just say finally and briefly, on a more optimistic note, I do think that policymakers recognize there is life in healthcare beyond the Affordable Care Act. And I think the big question over the next few years, as I said, I think change will be happening within a set of boundaries. But there are some really important questions, for example, like the structure of bureaucratic organizations and whether those bureaucratic organizations are ready and able to handle the innovation we're seeing coming out of the healthcare sector. I think those are the kinds of questions that finally policymakers will be willing to tackle. And I think that those are crucially important as we look not just at cancer care, but even beyond to the health of our healthcare system more generally. So I am hopeful that there is going to be some opportunity for activity in those areas.
Great. Liz?
So when I think about what's working well in healthcare and where we might need changes or where things aren't working well, I think what's working well is, first of all, we have 20 million new people who were previously uninsured who now have coverage. We have an uninsured rate that is below 10% for the first time in our nation's history. Despite recent upticks in spending, we've had slower rate of growth in healthcare spending over the last few years than we have over the last 50 years. And I think those are all really important accomplishments that really can't be denied. I think also the ACA's payment changes are encouraging more collaboration and innovation in a delivery sense. So you're starting to see doctors and hospitals and different players in the healthcare system work together in ways that we haven't ever seen before, and that sort of collaboration, I think, is a really good thing. And I think I just saw this morning there was an article that somebody posted to Facebook about that there has been $10 billion invested in new startup companies as a result of the ACA and all these new ideas. Healthcare is an area that is ripe for disruption and innovative ways of doing things. So I think there's a lot to be excited about and thankful for. I think on the areas that need to, where we need to keep a watch out, I'm personally very worried about cost sharing and the out-of-pocket burden that a lot of patients are asked to bear. I know insurers are trying to make premiums affordable, trying to make sure that people can still have access, but that has meant very high deductibles and I think high cost-sharing levels that worry me. And when you think about cancer patients and making sure that patients have access to needed care, that's one of the things that is on my mind as things to watch out for. So I guess, like Lonnie, I'm hopeful that we can get to a point where we can have, I guess, adult discussions about healthcare policy again in Washington and start thinking about what's working, what's not working, and what needs to change. Not quite there yet, but I'm hopeful that next year will bring those opportunities.
Great, thank you. Scott?
I think when I think about what worries me, I think when you look at the payment reform that's underway in the system and payment reform under Medicare, it's really all various forms of capitation. I think what's going to ultimately prevail and predominate coming out of things like the doc fix out of MACRA and coming out of the Affordable Care Act are going to be wholesale forms of capitating physicians like bundled payments. And I think those are terribly flawed models. So I think we're just swapping one bad payment system for another bad payment system where doctors are going to be given inordinate financial incentives to try to clamp down on costs and use of technology. And we've seen this in the dialysis bundle to some degree, where it's very hard to introduce new technology in the treatment of patients because the bundle makes it prohibitively expensive for providers to introduce new technology, and you're not seeing a lot of new technology get developed. And so that worries me. I'm also worried about the consolidation that's underway in the delivery system, and a lot of that's being driven by the payment reform. A lot of it's being driven by the pressure that physicians find themselves under in a reimbursement system where they don't see the reimbursement increasing. But I think that consolidation is going to be very hard to unwind. It's not like the 1990s where doctors are going to be able to break apart the relationships that they're forging with hospitals and go back to practicing. It's not as simple as just changing a tax ID anymore. The hospital owns your medical records. I think these are going to be sticky relationships. And we're effectively creating local monopolies, local healthcare monopolies. I think it's going to ultimately reduce competition at the local level and probably drive up prices and also reduce physician productivity. When doctors enter into these relationships, these own salaried relationships, there's very good evidence now that productivity declines. And if you think what we need to be doing to solve our long-term physical challenges is to get more health care for every dollar of GDP that we spend on it, the last thing you want to do is create a downward inflection and provide a productivity, and yet I think that's what we've done. On the consumer side, in terms of what I'm worried about the accommodations that we've made for the insurance market reforms to the structure of insurance itself. And by that I mean skinning down the insurance benefit to such a degree where there's not just very narrow provider networks now, but very narrow closed drug formularies where more and more patients are finding themselves completely off formulary and uncovered for important drugs. We've effectively left consumers underinsured for drugs. And I think that this is going to become, these models that right now are mostly seen in the Affordable Care Act are going to really become the de facto market standard because by sort of embracing them, if you will, or at least accepting them as an accommodation for what we've done in the Affordable Care Act, we've made them, if not politically popular, at least politically acceptable. In the same way when I was at CMS working on Medicare Part D, there was a deliberate decision made to use a 5-tier and 4-tier formulary to create the specialty tier as a way to hold down spending in Medicare Part D. And I think the government's embrace of that construct helped popularize that construct. Before we did that in Medicare Part D, about 15% of the market had specialty tiers, drug formularies, and right now it's probably like 80% today. And I think that's in part because the government embraced it and made it politically acceptable for consumer plans to do that, so it became the market standard. I think these very narrow networks, closed drug formularies, are going to very soon become the market standard, and we've left consumers underinsured, particularly for catastrophic illness. And if you believe what insurance isn't prepaid primary care benefits, but actually should insure you against a catastrophic, unforeseen illness, I think that's where people are getting squeezed. In terms of an optimistic note, I think something to be very optimistic for is just the pace of the technological change. The kinds of, not just the drugs that we're developing, but the kinds of platforms that we're using to create drugs really do open up the possibility for the first time of fundamental cures for inherited disorders, things like sickle cell disease. I mean, just 15, 20 years ago, it would have been really, it would have sounded dreamy to talk about curing sickle cell disease, and we might do it in 2 or 3 years, quite literally. And I think that's because, not just because of the sort of pace of technological change, but the pace of the translation of technological change. What we're seeing is, technology that was developed just maybe a decade ago is now being translated into treatments. And if you think about a sort of proxy, you look at the advent of monoclonal antibodies and sort of our modern understanding of immunity. We kind of developed the foundation for that technology and science in the 1970s. It really wasn't until late 1990s that we had the first monoclonal antibody on the market, so it took sort of 30 years for the translation of the fundamental scientific discoveries to relate into actual treatments for patients. And the first monoclonal antibody drugs were crude. Now we've fully humanized the antibodies. Now we have different immunotherapy, sort of a second generation of immunotherapy. We're not replacing the immune system. We're actually harnessing someone's innate immune system with drugs like ipilimumab. I think that's a 30-year journey, 40-year journey. Now we're seeing 10-year journeys, and that's something to be very optimistic for.
Great. So I'm actually going to answer the question I posed by just offering, because each of you kind of sparked something that has, some of you know I've kind of increased back into my clinical practice, which as a primary care physician in an accountable care organization in a pretty metropolitan kind of diverse area of Washington, D.C. feels a little bit like, oh, you get a little snapshot in what's happening.
So you're one of the own physicians I talked about.
I am.
Has your productivity gone down?
I am. So my productivity, so a couple of things that's fascinating is that the affordable care, we have more patients, to Liz's point, more patients that have come in that had never had care before, and they're pretty sick. So, I mean, it's not like there are some that are coming in for just well visits or, the physical that we can debate about whether we really need, but majority of them have had some set of issues. And if Terry Langbaum's in the room from Kimmel Cancer Center, I'm at Hopkins, and a lot of these patients are coming in from community-based settings, and they have had diagnoses around cancer, and then their primary care physician becomes the point of access. I'm very close to becoming a glorified bureaucratic gatekeeper in many ways, and I know that that's a very dirty word, but so much of my responsibility, and it's not even me, it's like our office's responsibility, is to kind of be the point of care, which one could argue could be coordinated care and lead to kind of these delivery reforms that I think we really want to get to value, et cetera. But the truth is that I'm measured still in like this fee-for-service world, and even in an ACO, I'm still kind of measured in a fee-for-service way. So my productivity, as well as my metrics that are given back to me, whether they're for CMS or for a private payer or just patient satisfaction scores, are kind of constantly displayed to these busy primary care docs. And then we don't really have a great feedback mechanism to change the way we do our work. So the reason I bring this up is because many of you are at the training and research and clinical institutions that are kind of the nexus of this intersection. And I think that it's not going to be, I think every panelist would agree that what makes this work is not going to come kind of top down from a policymaker or the government or a regulatory body. It's going to have to be from some kind of investment and leadership within our delivery systems that allow for the opportunity to be flexible to make these things work, as well as the acknowledgement, to Scott's point, that some things do not work. I'm a big person that says the ACO that we currently have should not be the accountable care organization we have in the future. And that's because there are many parts of it that just don't make sense, but we're a good foundation to get the conversation going. My fear is that as I watch kind of primary care, to be honest, the oncologists in the room can correct me if I'm wrong, we're still the lowest paid providers in the healthcare system, making a decent amount of money compared to Americans, but a lower paid system with this expectation that we're responsible for the millions of dollars that are generated in cost. And so there is going to have to be a conversation because of premiums, because of out-of-pocket sharing, cost sharing, that we will have to understand kind of what is our work worth and how are we measuring it. So I just couldn't help, I know that's, I shouldn't do that as a moderator, but I felt the need to kind of respond because it's only occurred to me lately that to make this work, we're not going to see more laws to launch, we're not going to see more things coming out of CMS, the White House, major insurance companies. We're going to have to figure out how to make it work, and that's going to be on us.
Can I make one response? I think, I agree with you. I think that what worries me is that we've sort of imposed one model of health delivery, the organization of physician services, when we tried to instigate the consolidation as a way to get physicians into units that were big enough in order to take the capitated risk. That's been the policy design from Washington. In an ideal environment, you'd want to create a regulatory structure that allowed a lot of different forms to take place in different markets, but we've sort of forced one form because of the way Washington operates. And what I worry about most of all is there's going to be consequences of that, especially in certain markets that can't accommodate that structure, others will, and then we're not going to be able to unwind it. Right. So we've sort of foreclosed different kinds of innovation in the organization of the delivery of healthcare services. And the other thing we've done under Medicare, and we've done this for many years, so this is sort of bipartisan folly, is whenever there's been a change and an innovation in healthcare delivery, the provider segment that introduced that change ultimately benefited, profited, earned above market rates of return on their invested capital, and we've punished them. Hospice was making more money than the average provider, so we cut their payment rates. They continue to make more money, so we sent the DOJ in to see if we can criminalize their activity. You can't punish innovation and success in entrepreneurship, and we've done that in services.
And that's where the new delivery models that allow for some broad waivers have also, I mean, I'm hoping we get to a point where everything is kind of adopted and it's not just people that are kind of invited or applied to be in some of these models that are successful. But, and then I will just finally say that people have been often asking in the audience about a comment that Andy Slavitt made about the end of meaningful use. He made a comment in a conference in San Francisco several months ago, and I think that that's kind of a false. Any of you who work with electronic medical records know we haven't ended meaningful use. We're just incorporating the use of electronic records in a different way into kind of the future of payment models. And I think that what we have to do is start to disconnect this perverse tie we have to the vendor industry and kind of what's been forced down our throats and what I would say is arcane and insane technology, and actually take that $10 billion in startups that are doing better approaches to technology in the delivery system and actually applaud some of those, because what we're seeing now is a monopoly of giants in the vendor space of electronic records that I think is not taking us into where we need to go.
Yeah, I'm on the committee that advises the federal government on meaningful use standards, the bipartisan committee, so I'm a bureaucrat, right? That's helping to destroy the practice of medicine.
Exactly, there you go. You can blame Scott. All right, so I will stop there. I promise I won't make my own comments. And let's actually shift now and focus a little more on cancer care. So maybe we can actually go, let me do a reverse and start with Scott and go back down to how people think cancer care is faring more specifically, and then just the perspectives. Each of you don't have to answer each perspective, but I do want to kind of bring in the variety of perspectives of stakeholders in cancer. We've talked about patients and we've talked about providers, but maybe we can go down a little further. And then also just, it occurs to me that each of you, I know personally, have been part of an academic institution, currently involved in an academic institution. So where do those kinds of organizations, and I realize this is throwing off a little bit what I said I would ask you, but just where does kind of the organizations that help train and do the research that we're talking about to take care of cancer patients kind of fit into how we see the evolving delivery system? So I'll start with you, Scott.
Well, yeah, I'll just pick up on the points I made. I think that I made those points in part because I think they're acutely pertinent in the realm of oncology. I think in oncology we see most acutely patients being underinsured for catastrophic costs. We've done a great job of helping patients get free access to surgical sterilization and dental care. And then when they get cancer, they can't afford the monoclonal antibodies because they're uncovered or the out-of-pockets are too high, or they're in a closed formulary that leaves them completely on their own for that. When I was undergoing treatment for cancer myself, I became particularly macabre, and I'm usually pretty macabre to begin with. And I used to ask people, I used to say, well, what's your coverage for dental care? And everyone knew their dental plan. What's your coverage for immunizations? And everyone knew it. And I said, well, what's your coverage for injectable monoclonal antibodies for oncology? And they looked at me like I was crazy. But if you think about an insurance product, you should be aware of what the coverage is, and it should be quite generous. And that's not what's happening. I think with respect to the consolidation, it's been particularly acute in this realm, in part because other forces are driving consolidation when it comes to oncology. Things like 340B are driving consolidation at a faster pace in oncology than in other areas. The other thing I'd say is that, you know, when the government steps in to try to regulate and control costs of healthcare, they're going to focus on technology, because technology becomes an easy input to try to use as a way to control what's happening on the delivery side. If you control a physician's access and use of technology, you effectively control the physician rather than try to control the physician more directly, which is a hard thing to do from a bureaucratic standpoint, from an administrative standpoint, and it's a hard thing to do politically. And I think this is an area of clinical medicine that's particularly dependent upon the new technology and the rapid introduction and diffusion of technology. And I think we're going to see in the future more and more the controls are going to try to put controls on access to and use of technology, because that's the place where you can potentially make policy. The other thing is that's the place where you have data. So it's easier to make policy when you have a lot of data associated with an activity or with a product. You can tie policy decisions to data points. On the delivery side, you don't have a lot of data around what physicians do and what's more efficient versus less efficient. So it's much harder to make policy, let alone try to implement it and drive physician behavior.
Great, thank you. Liz.
So I think your question was, what role do academic health centers play and
other stakeholders? If you want to, you talked a little bit about patients already, but you know, just kind of where in the spectrum of cancer care with different stakeholders, including some of the organizations that are sitting in this room, which are training, teaching, and research organizations.
Well, like I said, I think there's a lot more collaboration than there has been in the past, but could be even more. And I would like to see all stakeholders in the system working together, and that includes industry. So I'd like to, speaking on behalf of Janssen Pharmaceuticals and Johnson & Johnson, would like to be a partner at the table and viewed as a partner at the table, and really working with academic medical centers, with patients, and with the other payers and other actors in the system to improve cancer care. And I think one aspect you touched on was sharing of data. We don't have a lot of that, and I know we'll touch on some of the questions later on the cancer moonshot and the precision medicine, but I think one piece that's missing is the ability to share data across industry, across providers, for patients to get better access to their own data. So I think that's an area where there's a lot of room for improvement. And just again, putting on an industry hat, would like to make the message clear that industry wants to be at the table and wants to be part of the solution.
And do you feel like because research for kind of a long time, I think many clinical research or academic centers have had partnerships with industry, but they've been in the form of trial, drug development, drug discovery, right? So are you talking about something a little different, Liz? Or
let's extend out that time period into, now you have patients coming up and patient care and better use of evidence and data that's out there in terms of what's actually happening, the impact on patients, and feed that back in. Having a conversation with Lynn Fitzgerald last night about the NCCN guidelines and how they do rapid cycle updates. I mean, all of that information, making sure that it's getting in the right hands and shared across the different stakeholders in the system, I think is a positive development.
And that's also taking, I think, I'll say that certainly a lot of things have made it more difficult to have those frank dialogues and tables. The Sunshine Act, which, there's a lot of things that, again, going back to kind of this notion that what seemed like part of policy in a good context in some ways have created, I would say, a disruption of the ability to say, Liz, from a practicing clinician standpoint, we're finding X, Y, and Z, and how can you learn more about the products we're using and better tailor them to meet patients' needs.
Yeah, it's ended routine collaboration.
Right. So I've noticed that in some ways, ironically, it's been harder to do that because of some of the things we've actually done.
And just building on a point that Scott had made earlier, in terms of our regulatory structure, our regulatory system on health policy was built on a fee-for-service chassis.
Right.
Everything that our regulatory structure in terms of the payment, the reimbursement, the coverage issues are all based on fee-for-service in terms of what you can't do, what you can do. And I think we need to rethink that in light of a lot of the changes in the payment system. Whether or not those payment systems are moving in the right direction. Right now, we don't have the ability to do a lot of the things that we would like to do, and I think we'll get into this when we talk about value-based care and value-based payments, but it seems like we need almost a whole-scale revisiting of
the structure.
From the ground up.
I hear you. I think the challenge is, even if we move towards a capitated model where government agencies are just transferring risk to providers, as much as that model has its own flaws associated with it, what I worry about is it's going to still be hard for the agencies to give up control. So you're going to get the worst of both worlds. You're going to get the wholesale transfer of risk, and then you can still get the tinkering. They're not going to just say, here's the risk, you figure it out. And that's what we're seeing in dialysis to some degree, where you still see heavy regulation, and now they're on the hook for the risk. That's what I worry about.
And we've all played roles being a tinkerer.
Exactly. Well, it's hard not to. You get in those positions.
Great. Lonnie, any thoughts on the stakeholder perspective, and also maybe to kind of talk about where academic centers and organizations of teaching fit in?
I think from a more general perspective, being in an election year, it is not traditionally the case in an election year. I mean, let me just back up. It's very hard for issues to break through in any election year. Okay. Healthcare as a general issue is something that we've talked about in the past, but generally those debates have been around questions of coverage, right? Who's got a plan to do this, that, or the other. I think, interestingly enough, because of what's happened over the last few years, we are in an election cycle where it is possible that what I would term boutique issues can play more of a role. Okay, I consider, by the way, drug pricing to be a boutique issue. Mm-hmm. I don't see it as a comment on the health system. I see it as a relatively discrete issue. Some may disagree, but I see it as a discrete issue. I think with respect to oncology or to cancer care, I'm actually one of those people that thinks that this Medicare Part B demo will be a campaign issue. And it will be a campaign issue in this, not in the technical sense of, well, let's discuss specifically, are we talking about 2.5% or 4% or 6%? But, kind of to Scott's point, what is the appropriate role for government in setting payment policy, in influencing the kind of care and the routines of care and the episodes of care that patients receive? And I think there is a very fundamental question that will be discussed and debated about what the appropriate role is. Now, this is recognizing the fact that we have a front runner for one of the major party nominations now, whose health care plan consists of making things really terrific. Right? So,
Which one's that?
So I fully recognize that maybe this is fantasy land to think we're going to be talking about the Part B demo. So to get from terrific to the Part B demo, there's a long distance to traverse. I get that, but my point simply is this, which is that we are sort of in this world now where, as we make this transition from, however you want to call it, if you want to call it a transition from volume to value, if you want to talk about a transition from the existing healthcare system to a patient-centered healthcare system, whatever you want to call it, this transition is underway, and it has not been directly discussed in the political context in the past, but I do think now, with the Part B demo, it makes live this issue in a very real way. Academic medical centers, I'll just say, traditionally, I think that they have had a very sympathetic story to tell, and I do still think for policymakers it is indeed a good story, but I do think that there will be increasing pressure. Yeah. There will be increasing pressure on reimbursement. There'll be increasing pressure in terms of how academic medical centers integrate with other parts of the healthcare economy, and so I think as a result, those issues will also be more live over these next several months and years, because it is part of this basic question about what this transition will look like and the role of all the different pieces in this. Because, when we think about innovation, we've all talked about healthcare innovation. What we don't realize sometimes is how big of a role we have given government in driving that innovation. Mm-hmm. And so as a result, a lot of different parts of the healthcare economy, a lot of different sectors of the healthcare economy that may like to think that they're immune to government actually very much have to pay attention to what government is doing.
Lonnie, I know Scott wanted to ask or mention something and follow up. Can I ask you, since we're going to spend a little more time later on, I don't want to steal Marc's thunder, on a little bit of the politics and some of these issues, but just to ask you, when you were kind of working on the campaign, or even just in general, kind of when you were advising campaign candidates or presidents themselves, where did you find the conversation around cancer, that kind of what you're describing as a little bit of the niche issues? Yeah. How did that get elevated just in real life for you? Yeah, I mean, I would say in many cases it was very, very difficult. So, I was Governor Romney's chief policy advisor in 2012. And, I would take visits a lot of times with groups that would come in. Right. I'd take visits with cancer care organizations, Alzheimer's, mm-hmm. Parkinson's, all of the specialty groups. And everyone would want to know, how do we elevate this issue in the presidential campaign? How do we make this debate we're having over health care about our specific issue? Yeah. And I'd have to break the news to them that probably was never going to happen. Okay, yeah, that's what I... Because people were focused on, issues like, big issues like the federal debt and building walls and whatever it might be, right? Those are the issues that people are squarely focused on. And as a campaign, you're dealing in a cycle where the issue matrix is so broad. One day you're dealing with Libya. The next day you're dealing with, Social Security, disability insurance. And it's very difficult to elevate those boutique issues unless there's something in them, and I think the Part B demo has the potential for this. There is something in that issue that generates such significant and genuine concern amongst enough people
that it elevates to the level of dialogue that happens in a presidential campaign. Because if you turn on like CNN or MSNBC or whatever your favorite network is, chances are you're going to hear primarily political dialogue around what silly thing this politician or that politician said. If you're hearing discussion about issues, it has to be something pretty significant. For example, we're talking a lot about national security issues because of what happened in Brussels. That's a big thing. It is very, very difficult on a day-to-day basis for a campaign to charge ahead by talking about the very specific issues involved, for example, with cancer care or with Alzheimer's, or you fill in the blank, right? So I think that is part of the challenge here, unless, as I said, there is some animating issue that brings it to the fore.
Great. Scott, you wanted to respond?
I was going to say on the issue of the academic centers, unless the academic centers get subsidized out of the mistakes that they're making, I think the drive towards consolidation, the drive towards seeing these centers start their own health plans where they're taking actuarial risk, we've done this before, and it ended really badly, and I think they're going to come under pressure. If I was going to go into one profession right now that I think will be lucrative in 5 years, it'd be the distressed hospital business, helping distressed hospitals. The reality is there's sort of this perception, there was this perception, I think, in policy that if you just consolidate physicians, providers, you're going to get these magical innovations that are going to lead to better coordination of care. That's not how great innovation in healthcare services has come about. The hospitals have been adopters of innovations in the delivery of healthcare, but they've never pioneered them. They've always come out of venture-backed, entrepreneurial ventures, outpatient dialysis, skilled nursing facilities, home infusions. Those were all companies that were started by venture capitalists and eventually became mainstream concepts. And so I don't think that academic centers are just going to be able to innovate their way out of some of the bloat that they're taking on.
All right, Cibele, close us out on this topic. There's too much for you to say.
We've gone on such a far-ranging field. I'm not quite sure how to respond to it. So I think, I think quickly touching on something Scott had mentioned a while ago, when I look at the payment changes that I mentioned in the opening question, to me the issue is we keep looking for the sweet spot in a policy sense and in a clinical sense on the payment side between sort of pure capitation, where there's an incentive to undertreat, and pure fee-for-service, where there's the incentive to overtreat. And not by any of you in this room, but that there's just, we've seen the inflationary and deflationary aspects of both of those systems. And I think all the efforts right now and the experimentation that's out here on various ACO models, public and private, and bundling, of all sorts of body parts and procedures, is to try to figure out where that sweet spot is, where you have a bit more accountability and ability to measure clinical care and really watch what's going on and have, again, this right sizing of the incentives between everybody in the system. And trying to find that is something that I think is still elusive, but everybody's trying. Granted, I am not a practicing physician, and I can see how it's very difficult to be in a system that's in flux right now. But I think the status quo was indefensible, and we're trying to find a new way forward. I won't surprise you, being on the far left of the stage and perhaps the far left of the panel, that I think government can be a useful part of the solution and has been. DRGs came about through the government. Medicare has led the way in a lot of underlying payment issues that undergird the system, and without which we would be in 1965. Now, there's a lot of criticism for years that Medicare still was stuck in 1965, and then as we innovate, people say, well, now you're innovating too much, you're innovating the wrong way, and it leaves people stuck you're between a rock and a hard place. You don't want innovation, but you want change. The same thing, I think, in all these developments, we're in this essential balancing act between consolidation and coordination, right? In some markets, and it is, I think, very unique, you see some better coordination happening, whether driven by the hospitals or not, I think is a different story. I agree with Scott. I think a lot of it has to come from the ground up, from the practicing physicians. But if you look at what Farzad is doing in Aledade, I think that's really interesting. And they're going into rural areas, they're going into atypical markets and trying to give primary care doctors the tools to improve their feedback loop and to figure out what they're doing wrong and how to move forward. That's interesting. That ties back in what Liz was mentioning about all the startup and disruption investment that's going on right now in the market, and that's come about from the demands of the ACA that the system change. So I think, but you look at Boston, for example, and in many ways, obviously the consolidation there, is driving up prices, and it's an open question about how much of that is leading to better coordination. So we've got sort of a long continuum. One thing I think that we haven't talked about that much, and we may later in the questions, but that I did want to mention, is the promise of HIT. And I think where we're obviously falling very short on interoperability, and we can have all sorts of discussions and on meaningful use and what's fallen flat, what's fallen short, what should have been, what could have been. When I go back to when we wrote those provisions in the Recovery Act preceding the ACA, that was really about a number of things. I was working for a member at the time who had tried to put electronic health records in the 92, 93, 94 health reform effort. It had been a long sought goal, I think, of a lot of people looking at this going forward. He was a member from California. He was regularly, his family was treated on a bi-coastal basis, depending on where they were at the time. And he'd say it's not right. And of course, he was from California, where there was a more advanced electronic age at the time. Now, obviously, it's everywhere. But he'd say it's not right that we're in Washington, and then when we're out in California, nobody there knows what's happened to my family here. What can we do to make this better? Obviously, in the early 90s, we weren't well positioned to make that leap. But in 2009, when we put the health IT money on the table and had a lot of discussions around interoperability and how to get there, I think there was a concern. He was someone who was in favor of open source and said, let's go for an open source system. Let's not have vendor capture. Let's not have the things that, in fact, are happening today. And at one point, it wouldn't surprise you as a very liberal member, he said, let's actually require, this will make Lonnie and Scott want to set their hair on fire, let's require everybody use the same basic system, whether Vista or something else, and then have vendors do bells and whistles around that. But, so that as a practicing physician, when you go from place to place, whether you're in clinic, whether you're in the hospital, whether you're somewhere else, you are going to the same fields at every time. If you really wanted to use them to increase efficiency, you need to make it an automatic ability to use the tools no matter where you are. That's neither here nor there because it didn't happen, but I think the issue is we at least have the framework and the materials in place if we can stand to get the right rules in place to really encourage interoperability and break free of the vendor capture. And to me, the data possibilities that unlocks, particularly for the oncology community and other high-need patient areas, is phenomenal, not only in terms of patient care and improvements there, but increased efficiencies, reduction of unnecessary tests and duplication, and the prospects for health services research and clinical research just expand exponentially if we could really unlock the data. So that's...
I guess we should be happy we didn't standardize around DOS 2.0, right?
That's right, exactly. That would be really bad, wouldn't it?
But I'm just saying that there are a lot of different ways you can go about it. And right. I think one could easily argue right now, when we look back with hindsight to 7 years ago, that right. the political process which let some of the vendors ultimately dictate some of what's transpired both in the statute and the rollout has left us weaker than we should be as a nation for what was a $30 billion gross investment.
Right. But this is a basic question, right, for the healthcare system, which is what is the appropriate role of government in driving innovation, right? So the ACA sort of dictated certain kinds of innovation. And not all those things were bad.
I disagree.
But hold on a second. The ACA created a center for innovation in the government, right? There's something a little ironic about that in some ways, that you would have I said earlier that government drives innovation, and I think that that's kind of the policy environment we've put ourselves in. But what the ACA did do is the ACA did crown certain kinds of experiments as being better than others. And we can't avoid that fact. And again, some of it's turned out okay. Some of it, I think, will be a disaster going forward. But that's just the reality of it. And so my point simply is this. I'm not saying there's no role for government, I'm simply saying, what is the proper balance? And have we reached it? Are we there? I don't know that we are. And so I think that is going to be a fundamental question we're going to have to struggle with here over the next few years.
Liz, do you want to respond?
Yeah, I do want to disagree a little bit. Going back to what Cibele said, Medicare is the biggest payer in the system. So what Medicare does has an influence over the rest of the system.
And taxpayer funded.
And it's taxpayer funded. So the idea behind CMMI was to put money into a system to test ideas in the private sector. What could Medicare be doing better that's happening out in the private sector? What innovation is happening out there that Medicare ought to look at? And if it works in Medicare, maybe we ought to think about expanding it. So it was supposed to be more of a feedback loop. And I think, you know, whether you believe it's succeeded or not, that was the general idea. It was not to bring government into, you know, dictating what should be the innovation. And in fact, the language was fairly broad in terms of, here's some ideas, but we really, you know, and going back to putting on an old hat and with Cibele, when we were working on ACA, and tried to figure out what is out there that will make our healthcare system better and more efficient. There weren't a lot of ideas out there. I mean, we had a few ideas. Mark McClellan and Dartmouth brought us ACOs, Elliot Fisher, some ideas around bundled payment coming from the dialysis space, thinking about different ways of paying for care, but there really weren't a lot of ideas, and so that was the idea behind CMMI, was bring us your ideas and let's have a way to integrate those ideas into the current system and figure out whether they're working. And if you think about the old cycle before, how we did innovation in Medicare before, there would be a pilot that was prescribed by Congress, and then CMS would implement it, and it would take 3 to 5 years to get feedback, and then it would take another act of Congress, if it was working, to actually implement it. It was a very slow cycle. So this was really
so then that suggests that Medicare, that we've got Medicare wrong then, right? Because the model that you've described, the idea of having pilot success, CMS, let's find some way to put it back into the statute, suggests to me at least that there's a fundamental problem with Medicare, that this is a Medicare system problem, in the sense that Medicare, again, as we talk about migration away from fee-for-service, which everyone agrees fee-for-service has its problems, right? That, in fact, the bigger issue we have is a structural issue with Medicare, not a sort of, again, CMMI to me strikes me, I mean, it is sort of forced innovation by another name. That's the way I see it. And again, this is my opinion, you have your opinion, it's different, I get that. But I'm just saying the way I view it is,
well, it's trying to force on the entire market success, local success, and I don't think
it works.
But I don't think you can necessarily do that in healthcare. There's a reason why Intermountain Health works in that region in Salt Lake City. There's a reason why Geisinger works where it is. Healthcare is a very local endeavor. There's a lot of unique characteristics of different markets, and the goal of CMMI is to find something working in one local market and then roll it out nationally. If you look back at President Obama's speeches about the Affordable Care Act before passage, there probably wasn't a single speech where he didn't mention Intermountain Health, Geisinger, Mayo Clinic. Probably not a single one where he didn't mention one of those three. Those three institutions were out probably of maybe 10, maybe less than that survived the wave of consolidation in the 1990s that all became unbundled. So every other institution broke up their consolidated delivery systems. A handful survived, and that became the template for the Affordable Care Act, quite literally. I mean, in terms of innovation, we can debate whether or not, ACA is impeding innovation or facilitating it. The reality is there isn't innovation taking place in the private market. If you look at venture capital into healthcare services, all the venture capital is going into healthcare IT plays. There's been almost no new facilities-based startups backed by venture capitalists. There's been no new net health plan formation since 2008. And you talk about things like Aliday, the practice management company that was started by Farzad, to roll up physicians and create a private alternative to doctors, to hospitals buying doctors. We did that in the 1990s too, with companies like FICOR and MedPartners, and I was just old enough to be at an investment bank that took public FICOR and MedPartners, so I kind of remember that experience. It would seem to me that this is an opportune time for a private capital to come into the market to consolidate physicians as an alternative to doctors selling their practices to hospitals, yet there's no capital coming into the market to do it. Aliday is one of probably only 2 practice management startups that I know of. all the private capital that's coming into the market for consolidation plays is consolidating facilities, hospitals, nursing homes, things like that.
But there's this article that Liz referenced this morning that I'd seen too, that does talk about the $10 billion that's gone in, and it's all over the place.
It's private equity. Every time I have this conversation with people, they talk about the money that's going in, and it's all private equity firms that are consolidating. That most of it. I mean, the big checks are private equity. I work at a venture capital firm. We're one of the few still making investments in healthcare services. Most of it's private equity. They're the ones writing the big checks, and they account for the lion's share of the capital that gets reported. It's not venture capital starting new ideas, not in services. The venture capital is getting channeled into services is all health IT plays that don't require as big upfront investments, don't require you to purchase facilities.
But whether it's a facility purchase or not, the point being is I do think that the ACA established the framework and the incentives and put the meat out there for people to come to the table and try to innovate and try to respond to a changing market. And so when you look at the article that's out there today that also details a few things. Farzad is one of them mentioned, but a home health play, a lot of it does have an IT-based platform. That still doesn't mean it's not a material improvement in what we're doing today. And we all know, at any time we've been patients ourselves, the system is flawed, is deeply flawed. And it's flawed no matter where you are in the world. I was meeting in, Canada the other day with Canadian investors. They're investors making a mint off of our flawed market right now. But they looked at me and said, why do you do what you do? So, I think it's mystifying. And one of the guys I met with said, I'm so happy to be back in Canada. But he said, at tax time and when I go to the ED, I'm not so happy. He said, still on balance, I'd rather be here. So no matter where you go, there you are. And we have a lot of problems here. And I think the point is we are at a time right now of tremendous experimentation. And I think putting on a government hat and a public policy hat, you're always trying to balance the desire to innovate, to do more, having the private sector do more, having the public sector do more, with the possible harm that could be done, right? In Medicare, we never want to make a huge payment change without having a sense of how it's going to play out, because you make a tremendous shift in the market and you can really jeopardize patient care and access and the stability of the system. So you have to proceed gently and carefully, and you have to always be mindful that you have taxpayer dollars behind it. So when we get back to what Scott was mentioning earlier about his concern that the system contracts and punishes those who succeed, I think that may be a little bit overly simplistic, because when we look, for example, if you follow what MedPAC writes on the various provider sectors, when you have the post-acute guys making double-digit profit margins on Medicare, and you look at the hospitals and the academic medical centers on a very thin line, and you say, what do we need to do to right-size this to ensure that the academic medical centers can continue to meet their AAA need where they are? And maybe the post-acute guys don't need to be giving so much back to their shareholders. Maybe they could do with a little less so that we can stabilize other parts of the system. And you're continuously having to balance those needs.
Yeah. I'll give you a practical example of balancing those needs. We cap the operating margins of health plans, the MLR caps, which I think you were against, but I don't want to out you. So we said health plans can only spend a certain amount of their revenue that they generate off of their premiums on the actual operation of the plan. It turns out that if you're going to start a new health plan, you have to spend 30–40% of your revenue on the startup costs, the operation of the plan. So what have we seen in the market? Nobody's starting new health plans. Nobody can get the capital to sustain losses for 7 years because the government capped their operating margin. That's what happens when you step in.
Oscar, you got an Oscar, right?
Oscar's losing a lot of money.
Yeah, that's because of risk selection.
California, they have no enrollees.
Right,
Oscar will not be here in 3 years.
Right.
Sorry.
All right, so let's shift a little bit.
Can I say one more thing?
All right, one more thing.
And then Mark's going to take over.
Talking about CMMI and the role and testing small things, and I think that is part of the concern about the Part B rule, is really taking, without testing first, some of the concepts in that proposal and making them virtually nationwide. And I think that's part of the concern, and it goes a little bit against what we've been talking about here about the innovation you want to see and test it first. And if it works, then it becomes something you want to try to expand. Yeah. And I agree with Scott that healthcare is local, but I'm not sure that taking cancer care and by zip code and trying this experiment across the whole country is what we had in mind. So yeah. I have some concerns about that. Also, I want to say that, value-based care is the way we're moving. As a company, we're in favor of value-based care, but I think this rule goes much far beyond that. So.
Right. Well, let's pick up on that, and we can start at the end. But we definitely want to talk. Obviously, we have a spirited group, and we're all friends, and we want to talk a little bit about specific cancer care issues. This Part B demonstration.
And not everybody may know what it is.
So okay, so there is a proposal within CMMI, the Center for Medicare and Medicaid Innovation, as we've talked about, to change payment for infused and injected drugs from the statutorily construct of ASP +6 to a lesser amount. And then to also move on after that and explore and experiment with things like bundles and reference pricing, indication-based pricing, combination pricing, and such. And, just to be very general, and then we can get more specific, and maybe starting, Cibele, with you at the end, just talk a little bit about how you see, this meting out and the impact.
And Cibele, maybe do us a favor and just give us, because we've talked so much about CMMI, but just kind of the bullet point facts on CMMI since.
Yeah. So the Innovation Center, as Liz and others have mentioned, was created in the Affordable Care Act, and it essentially was drawn from this notion that we had a very cumbersome process to introduce new payment policies to Medicare in the past that required congressional action, usually not once but twice. And if you haven't noticed lately, Congress is not doing a lot of legislating in the last few years, and especially, frankly, since we took care of the SGR. That had been an annual vehicle that could carry on, for better or for worse, depending on the policies on the table and your perspective, legislative changes. So every year you were sort of guaranteed, or maybe every other year if we bought a 2-year stay of execution, you could get out there and, with your various pieces, move something along. With that off the table, we're not seeing much health legislating now, despite the rhetorical flourishes that Lonnie has talked about earlier and where we are. So the Innovation Center, of course, was looking at this and said, okay, what can we do to put a framework out here to more readily test and potentially expand new ideas? And it essentially said, as Liz had mentioned, it's a very broad framework. Said, we want you to bring us ideas, and we, by the way, might generate ideas that are designed to maintain or increase access, to maintain or increase quality, and to maintain or decrease spending. And those prongs are important, because once you use that to design the demonstration and you put it out there in the formal rulemaking process and it goes underway, the actuary has to do a report and evaluation and sort of determine whether those prongs have been met. If those prongs are met, they can proceed apace and expand it more broadly without any congressional action. Frankly, there were members on the House side, my members, who were worried about this broad authority because they said, we're not always going to hold the White House, and do we want, at the time, Speaker Ryan in the vice president's seat helping to dictate a move toward premium support? And there's some open question about whether you could do that under the Innovation Center.
You can, or you can't.
So it's a huge, a potentially huge give of authority to the administration. And some members were nervous about that. But nonetheless, it was one of the promises that people were looking forward to in terms of sparking innovation and the potential for cost containment while preserving access and quality. Fast forward, and that was out there. We're now 6 years almost to the day since the ACA was signed into law, and only one so far has met those tests. And even that, to Scott's point about healthcare being local, is not something they felt they could or should expand nationwide because the communities aren't all ready for it. So I think as we look at the Part B demo, and I agree with Liz, it's a very aggressive play to propose it mandatory and nationally, and it may or may not comport with the thinking behind
or the law.
where we should go.
Yeah.
The language. So there's a debate whether it's legal.
Well, right. Well, there's the spirit of the law. There's the spirit of the law, and there's the letter of the law.
Well,
and I'm not defending it, but I'm simply saying that it's a big play out there, and I think it's important though to also realize this still isn't a wham bam thank you ma'am process that turns around on a dime and is suddenly there. That said, I think it's also important to realize that the ASP, the average sales price system for the Part B drugs, is a mess. It is not good policy, and I think people have known that for a long time. And on one hand, you'd say Medicare, as a taxpayer-funded program, shouldn't pay the average for anything. As the big payer with a disproportionate share of users, we should be trying to get the best deal possible on behalf of the patients, clinicians, and taxpayers who are involved in the delivery and receipt of these products. So I think it is important to realize the ASP system is not a grand system. Now, that aside, this is big. It is potentially an overreach. I think people did not initially conceive of this as a mandatory rollout over 5 years. And I think we're at the point where they are receiving comments, and the comments from the community are important. Going back to Kavita's earlier request about where can the stakeholders weigh in and what matters, it matters. The community feedback matters, and the agency will be listening. Would say that there's been a huge hue and cry, obviously, from this community and others, but you have AARP and some of the independent beneficiary groups saying, go forth and prosper. And you have a huge silence among a number of the other players. So I think it remains to be seen what they finalize and where they go forward, but I think input matters. And I think defending the status quo isn't the way forward. The question is how to say, what should we do differently? And I would think that the agency would react more positively to people not saying, no, 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 but do this instead. Look at it this way. Do it more constrained.
Yeah, I mean, I think the issue is, are we in a bits and parts negotiation now, right? Because I think you're right, there is input coming in. So then are we talking about ASP plus 6.5 versus, so 6.5 and 2, you could say, well, let's split the difference and let's go to 4. But really, I think you're right. The bigger question is, how do you take the status quo? I mean, do you defend the status quo or do you attempt to move it in a different direction? And I guess, even if we have this discussion and we end up at, some number that may be more acceptable to those who oppose the current rule, again, it's sort of like, are we in a position, should we accept that the right thing to do is to move away from the status quo and therefore move toward the Part B rule, the new Part B, the demo, excuse me, or are we saying, we don't like this at all? And I think that, that's a question that we're going to have to sort out, because at the end of the day, if it's a 60% cut, is it more acceptable if it's a 30% cut? I mean, I don't know. I don't know the answer to that, and some people in this room are going to have to make that decision about whether that's okay for them or not. But the bigger issue here is, are we going to be in a situation where we're accepting of the fact that the status quo is broken to a certain degree? And then if we accept that, then, what is the right way forward? Is it a less prescriptive way forward? And I think the other thing with Part B, by the way, is the Part B demo is how does it layer with the existing cancer care demo, I think it is, right? Yeah, the oncology care demo. How do those two things work together? And I don't know that was really well thought through. And I think a lot of people would have had, particularly in this room, would have had more comfort if there was some discussion about, well, how are those two pieces going to fit together? Because right now it's not clear to me that they do.
Right.
I think we need to step back and think about cancer care and the bigger picture. So we're at the age of great medical breakthrough. Close to 85% of the breakthrough designations at FDA are in the oncology space. We have the cancer moonshot with a lot more attention paid, precision medicine, a lot of great things coming down the line. Are we adequately prepared when they are launched to be able to pay for them and get them to patients that need them? And I'm not sure we're thinking about this in a big picture sort of way. And we don't want to make all this investment and all this excitement about the innovation side, and then come out, you launch your drug, and you can't get it paid for under Medicare, and patients can't get access. And I don't know that people are really thinking about the juxtaposition of the two, you know, the moonshot and precision medicine, and then the Part B rule. And I think you have to think about this as a whole. And, you know, ASP plus 6 may not be the right payment methodology, but I'm not sure that just cutting it down and giving a fixed price and then moving immediately into completely untested waters is the way to go. And I think we really need to step back and think about that as a community and with all stakeholders at the table. As Cibele said, I think the agency is looking for input. And we all need to speak up if this isn't the right path forward.
You know, I to pick up on Lonnie's point, I think I agree with you, Lonnie. I think, probably not surprised by that, I think this was a chance to fundamentally rethink about how we pay for Part B drugs and maybe move it into a different kind of scheme, and maybe a more competitive scheme like the way we pay for small molecule drugs on Part D, and rather than just change how we tinker with the existing rules and change the percentage. And we haven't done that. And sort of by continuing to go down the path of just tinkering with the existing model, it makes it that much harder. There's that much more corrosion in the system, and it becomes that much harder to fundamentally rethink about a completely different alternative. I will say that I think the far more significant part of that rule is Part 2 of that rule, which doesn't go into effect in 2017, where CMS has basically usurped for itself the ability to gauge and test forms of reference pricing around Part B drugs more generally. And they basically decreed for themselves the ability to say that within categories of drugs that they think are clinically interchangeable, they're only going to pay for the least costly alternative option within those categories. And so we're going to leave it up to CMS to decide which drugs can be used interchangeably. Maybe all TNF inhibitors, maybe all EGFR inhibitors are interchangeable in their eyes, clinically interchangeable, not really distinguishable. They're only going to pay for the least costly alternative option within any of those categories. This is in the rule. It's not spelled out in great detail. They'll have to issue probably subsequent regulation guidance to articulate it. If you want a clear articulation of what this would look like, look at the Center for American Progress, which is a left-of-center think tank. A lot of the intellectual engine for the Clinton campaign, not to be pejorative or political, but that's a fact. On September 18th, 2015, on a Friday, they put out a report on what they proposed to do for drug pricing, much of which Secretary Clinton's embraced, where they spell out the same scheme. The reason I remember that date is because on Sunday, Mrs. Clinton tweeted about drug pricing, and the following week the IBB dropped 50%. So I just remember the date. Friday was a demarcation for my portfolio. But if you want to see what the Part 2 of the rule looks like, and you can't glean it from the rule itself, because you really can't, go look at the CAP report. They're indistinguishable.
Yeah. Let's talk a little bit, as we sort of close out. How should policymakers balance cost, access, and innovation? We've talked a lot about innovation, and we've used it. We're throwing in those options of cost and access. You know, as Liz said, picking up on the moonshot, precision medicine, certainly the changes that are going on in Part B drugs, and what I expect will be changes in Part D as well, which is allowed both under the statute and certainly what CMS is doing, their broad demonstration authority.
Look, I think if you have the right payment system in place, policymakers should have a limited role other than trying to facilitate, rapid entry into the market of innovation. A lot of that deals with FDA. I think if we had a system where people could really, truly price products based on the value that they're delivering in the marketplace, there should be very little tinkering by policymakers around, are we paying too much for this and too little for this? The problem is, we have, in my view, a lot of government rules that get in the way of companies doing smart things around their pricing differently for the same drug, depending on what indication it's being prescribed for, pricing differently for a drug based on what outcomes it's delivering or the setting in which it's being used. Those things are exceedingly hard to do in the market because price-fixing programs that exist right now, like 340B, Medicaid Best Price, ASP, that require mandatory reporting of discounts to the government, end up preventing drug makers from having the ability to discount in certain settings. And then also Food and Drug Administration regulation on commercial speech, which might or might not even be legally supportable in terms of the FDA's regulation of commercial speech. The fear that FDA is going to regulate commercial speech nonetheless prohibits drug companies from crafting contracts on the basis of outcomes that aren't necessarily clearly spelled out in a drug's label. And so these kinds of things prevent a dynamic pricing system, in my view. And so you get the wrong prices. You don't get prices based on what's being delivered necessarily to the patient. And so then that begets more regulation.
Mm-hmm. Liz.
So I think, first of all, again, stepping back, I like the big picture. One of my favorite quotes is actually by Zeke Emanuel. We were just talking about. He said in 2010 that the U.S. spends as much on healthcare as the entire GDP of France, which is the world's 5th largest economy. I looked that up. It was true then. Today, we spend about as much as the world's 4th largest economy on our healthcare system. So we have a system that needs to change, and I think all of us here have acknowledged that. And all pieces of the system. It's not, I think what has frustrated me watching from my current perspective as well as my previous perspective is everybody sort of points a finger at each other. It's always somebody else's fault why the system doesn't work well. And in my current role, where I have been able to travel around and learn about other countries' healthcare systems, I get a better perspective on our system. I think it's all of our fault. I mean, everybody has played a role in making our system what it is today, and we all have to take part in working towards the solution and get away from the political rhetoric and really start thinking about solutions. So maybe fee-for-service, pure fee-for-service is not the right approach. Maybe pure capitation isn't the right approach. What I hear Cibele, the way that she framed it, I thought was really excellent, which is we're looking for something in the middle that rewards quality, that rewards outcomes, that allows for innovation and patient access and maintains patient access. And I think keeping all of those points in mind, we're moving towards a value-based world, and I think all pieces of the healthcare system are moving in that direction. But we have a system that is built, again, on a fee-for-service chassis. So just give you an example, if a drug company would like to do more value-based, outcomes-based contracting, which J&J would like to do, we have been in that space and would like to do more of that. We can't because of the existing regulations. We can't because of FDA, which doesn't let us talk about our data on better outcomes. We can't because the current ASP and Medicaid best price keep us from being able to strike these deals. We can't because of the IT systems, which keep doctors and hospitals from really knowing what the outcomes are and feeding that information back into the system that allows these contracts to be in place. So I mean, I really think it's a system-level issue that we need to tackle collectively, and going back to all stakeholders sitting at the table and being part of the solution. Mm-hmm.
Yeah, I mean, I agree with the idea that our regulatory framework and the way that government interacts with all elements of the healthcare system is built off of this, as you say, fee-for-service chassis, which I think is a very elegant way of describing it, that is 50 years old, basically. And so the big question in my mind is whether we will see some kind of reform of the regulatory system in healthcare that has to happen, I think, over the next 4 or 5 years. It's a critical thing, because we do have all elements of the healthcare economy moving toward a patient-centered, value-driven system. But I'm not sure that we have the regulatory capacity to support that quite yet. Yep. And whether it's FDA thinking about the approval of new cures, whether it's CMS thinking about coverage decisions, or the interaction between coverage at the state and local level with what the federal government's trying to promote, I just don't know that we're there yet. And I think policymakers haven't really focused too much attention on this question. They're starting to. I think 21st Century Cures, which is sort of the first effort at that, I think, begins to try to answer some of those questions, but maybe not in a satisfactory way to be sustainable for the long run. I think for the long run, we really do have to think about the way all of these different regulatory pieces fit together or don't fit together as the healthcare economy makes this transition. Because the worst thing that would happen would be for the healthcare economy to almost fully make this transition, which in some cases, we're starting to see it pretty comprehensively changed, right? Whether it's models of care that you're seeing in California, whether it's Kaiser or in some other parts of the country, Geisinger, Intermountain, et cetera, is the regulatory system ready for that or not? And that I don't know. And I do think policymakers need to pay more attention to those questions very, very soon. Because if not, we're setting up, again, for a system where innovation, the pace of innovation on the outside exceeds the pace of innovation on the inside. You have a problem. And right now, that seems to be where we're headed.
I think we're all in agreement then?
Yeah.
I was going to say, I think, what I hear everybody talking about, and this is certainly, I think, going to Liz's point up at the macro level, what keeps me up at night worried about is how we balance innovation and affordability, right? And that's what we have not figured out yet. And in fact, I'd argue I'm not sure anybody in the world has figured that out quite right yet. And it may be, the elusive Holy Grail. But it still should be something we're striving for. And one of the other things that worries me is, Liz is exactly right. The pipeline right now is so promising and interesting. The scientific developments that we've seen in the last few years and that are on the horizon potentially are truly, life-changing sounds so trite, but it's really incredible what could be there. And yet, if you look back on the last 2 years, it will make the Hep C drugs look like a blip. Depending on what comes forward and the pricing structure, it could force a very different conversation very quickly. And how are we going to ensure access? You have these wonderful products that could come to market that could truly change the course of people's lives, the trajectory of their treatment, and where do you go? And in the US, where there's so much fear around good data and how that can be used to drive, not to ration, but to help people understand. The whole point, for example, we haven't mentioned this up here at all, and I think the effort, in my eyes, has not met our expectations even remotely on PCORI, was to arm clinicians and patients with information, right? To help them better understand the comparative treatments, within a therapy line, or surgery versus a therapeutic, et cetera. And the whole process has been hamstrung by people who were afraid of how the information could be used. And so they're in this damned if they do, damned if they don't position. If they produce something that's interesting, they'll be killed in the cradle by the interests who feel threatened. And if they haven't produced anything of interest, they'll be killed for not doing anything. And I think we have to move forward into a more robust discussion using data and information once we get it to really help drive decisions. But again, if these interesting therapies come out and we see launch prices, in line with the recent past, it's going to bring a real conversation much faster than people are ready for.
But I think also, and I think those are good points, but I think also the problem that we have in the U.S. health system is that you can change your health plan every year.
Right.
And so we live in a world where people look at healthcare costs and spending in a year-to-year increment instead of over the lifetime or a bigger picture.
The investment.
And I think...
Well, a consolidated delivery system is taking capitated risk in a local market doesn't think that way. And I think the discussion, if that's the direction we're going in, and I think it's the direction we're going in for better or for worse, the discussion around the technology shouldn't happen with an insurance company. An insurance company could facilitate that discussion. It should happen with the providers that are taking local capitated risk in perpetuity, because they're not churning their local market. They have 6% that moves in and out of their market each year, but they're owning that morbidity for an extended period of time. They're going to have a much different perspective on making an investment in reducing the local morbidity. For a local health system that's taking capitated risk, that's consolidated its market, it might make a lot of sense to cure everyone in that market of hepatitis C. You reduce needle stick injuries, you decrease your run rate on your morbidity and mortality, and you're going to reduce your 5-year costs. That looks different to an insurance company.
Absolutely.
But only if the payment system rewards that. I mean, it's all about the incentives in the system. Are we really set up for the right incentives?
The payment system isn't going to reward it necessarily. What the payment system is doing under MACRA and the Affordable Care Act, in my view, is just transferring risk. I think all these contrived things like medical homes and accountable care organizations with the government trying to tinker around the incentive structure, I don't think Medicare is going to be able to administer that. What Medicare will be able to administer in the long run, the private market will follow, is wholesale capitation, bundling wholesale transfers of capitated risk. Here's a lump sum of money, you deal with it. You take the actuarial risk. That's where I think it's going to end up.
Yeah.
Could be wrong.
Let's, as we close out, last couple minutes, this is a political panel, and we'd probably be remiss, and the audience would probably miss out if we didn't ask folks their prediction, and more so if it's, maybe the most important thing, is it a positive or negative for cancer and for cancer care? So I'm going to start with Kavita. give your
I
political
think,
prediction.
I know.
Over
I learned
under.
not to try to predict presidential candidates, but I do think Clinton will eke this out. Low voter turnout will benefit her, and she's got the blue wall on her side of delegates and numbers, even though Sanders is kind of closing in. So I think it'll be Clinton. It'll be kind of more of what we're seeing now, with some tweaks, since she's very interested in IT and kind of personally pushed on the Senate side a lot of the meaningful use in HIT pieces. I think she'll kind of take hold of some of these things, as well as drug pricing. I think Scott's right. You can look to some of the CAP reports to see kind of inklings of where they would concentrate on the first 100 days.
I think Trump loses Wisconsin badly. It becomes mathematically very, very hard, if not impossible, for him to win the nomination outright with 1237 if he loses Wisconsin. He's also going to lose momentum, and he's already polling down in states that he needed to win big, like California and Pennsylvania. So it goes to a brokered convention, and Cruz is doing a very good job organizing the delegates. Cruz has had an exceptionally good organization from the start. Not very well known, I think, outside Washington, but he has a good organization, and I think he'll be able to pull it out on the convention floor.
But does he win the election?
That's going to be a tough election. He might be the only person who can lose to Clinton this cycle.
There you go.
Well, I'm not going to make a prediction. I mean, obviously, given my background, you know where I stand, and I'm hoping that the person who cares most about policy is the one that wins at the end of the day, because at the end of the day, we still have to govern the country.
Yeah.
And I haven't seen much of a policy debate, but what I really hope is that we can get back to policy. And obviously, I'm in favor of Clinton strongly, and would like to see that, but I'm not going to make a prediction.
Yeah, I mean, I think Scott's insights were good. I think what people don't realize is that if Trump is unable to get to the requirement of 1,237 delegates before the convention, I have a very difficult time seeing how he can be the nominee. I know that sounds a little weird because of his riots in the streets comment, you know, that like if he has the most number of delegates, he doesn't understand how someone could take it away from him, and maybe there will be riots in Cleveland if that happens. But the reality is the party rules say that if someone doesn't have a majority of delegates on the first ballot, it goes to subsequent ballots. And to Scott's point, there is a lot of organization out there that people aren't following. That, you know, yes, Ted Cruz, I think, is very well organized. I think he would be in a good position to win. It's entirely possible, too, that it could be someone that isn't named Ted Cruz, John Kasich, or Donald Trump as the nominee. That's the whole idea behind an open convention, is that the convention is open. And, you know, I think the rules after you get past the second ballot get even murkier. Delegates sort of are free even to vote their own conscience even more after the second ballot. I do think we're headed for an open convention. I do think that the throw weight of all of Trump's comments are starting to erode his numbers to a point where it may not be sustainable for him beyond Wisconsin to continue to do as well as he's been doing. I think he'll still do decently well because the anti-Trump vote is still divided, and I don't see John Kasich getting out anytime soon. So it's a very messy situation. I think for a lot of Republicans, the preference would be to like move somewhere else for a few months and just hope that hope that this resolves and then come back.
Wake you when it's over.
Yeah, just wake me up when it's
It really
done,
is
because
depressing.
this is bad news, man. Really bad news.
Lo siento. And you know, there's a part that would be almost entertaining on my side of the aisle watching this, except it's so terrifying for all of us. So I think, like Liz, I'm not necessarily going to make a prediction, in part because of Lanhi's comments that we really don't know what's coming out of their convention. And I think, you know, it's still a long time between now and November. You know, I obviously have my dreams, and I think that Senator Mrs. Candidate Clinton, Secretary, would do well. I will say, bringing it back to sort of the origins of the question around cancer care, this really does matter, and elections do matter. Either candidate is going to face, whoever gets elected will face almost surely either closely divided Congress or an all-Republican Congress. So I will say that we can do a quick if-then. If Senator Clinton wins, Secretary Clinton, I'm still not sure, candidate Clinton, you know, she's going to be facing maybe a Democratic Senate, depending on the coattails of that, but almost certainly a still fairly strongly Republican House. that is a recipe, if passed as prologue, for some amount of gridlock, especially on healthcare issues. And you would think that they'll continue to use the authorities that are given to CMS and HHS to do what they can on a regulatory front. I think the asterisk is if they would end up in a big budget negotiation, and if she and Speaker Ryan are in the room negotiating something, you can't get there from here without a lot of Medicare and potentially Medicaid on the line, and then there's an open door for a whole lot of things. If one of the Republicans wins, however, in my view, from a healthcare standpoint, there's a lot to be concerned about. The rhetoric around the ACA has been so toxic, and people are so dug in on the repeal and replace rhetoric with no good replacement options revealed yet. And I think they would have to go through the motions of repeal. And that is taking away health care from millions of people and upsetting a sixth of our economy in a very material way if they made good on a wholesale repeal, including of all the Medicare changes. Now, they could take a Speaker Ryan approach and repeal only the coverage investments while retaining all of the Medicare pieces. But no matter how you go about it, what I like to say is there'll be a little bit of the dog that caught the car, because now what? We run the table, if you're a Republican, we have to do a repeal. What are we going to replace it with, and how? And it could be a very disruptive and noisy conversation. The question is, what would actually happen? And I don't have the answer for that, but I think it would be very interesting.
We'll send, we wrote a really good replacement plan. We'll send it to
Yeah. All right. Well, with that, I guess our time is over. Some of our panelists will be around if folks have questions. And thank you very much.
Thanks a lot.